Hello, this is Dr. Gay from First Look MRI, and this is an 18-year-old male with complaints of left shoulder pain for a few months, no prior injury, just pain, and the doctor thought they had a slap tear, a tear of their labrum, the superior labrum, and so they did an MRI with arthrogram, with the fluid filling the joint. This white stuff is fluid here, and the fluid is filling the joint so it outlines the labrum, and if there is a labral tear, it'll show up better. So in this patient, we see the humeral head is round. It rotates in this little cup called the glenoid, part of the scapula. This is the body of the scapula here. We see white signal. This is fluid. This is contrast within the joint that's been injected from an arthrogram, and it distends the joint, outlines the labrum, which is a little black wedge, a fibrocartilaginous wedge that goes around the rim of this cup. It's so small, it blends with the cortex. You can't even really see it here, but it goes around the rim, and this little part right here is the posterior labrum. Here's the anterior labrum. As we go up to the top, this is the very top of the labrum. It looks normal. If we go down towards the bottom, it looks normal. So I do not see a slap tear like they thought clinically. Here's the superior labrum, inferior labrum looking normal. Here's the superior labrum, here's the inferior labrum looking normal. So this all looks very good. Now in this patient, the rotator cuff looked good as well. This is the supraspinatus muscle, supraspinatus tendon coming down here, attaching on the greater tuberosity footprint. There was no tendinopathy, no tear. Again, the humeral head, the articular surface look normal, so everything's looking pretty doggone good. If we roll towards the front and towards the back, things are good, but on this view we do catch one subtle finding over here. We see this part of the rotator cuff back here. This is the posterior inferior margin of the rotator cuff. We have the infraspinatus muscle coming sideways here. We have the deltoid over here, and down here we have the teres minor muscle. And we can see that this is a little smaller than we like, and it's a little bit brighter than the other muscles. All these other muscles are uniform dark, and this is a little brighter, so this is the main finding. If we look on this view here, this is a T1 weighted image. We shouldn't see anything on this very well. It looks about the same because this is not very sensitive. But if we go to this view, it really stands out. This is a fat suppressed protein density sequence. Now we really see this difference in signal a little bit better. So this is edema within the teres minor muscle. This is a coronal view here. I'm sorry, sagittal view rather. On the sagittal view, we see the rotator cuff muscles, and if we go towards the central, medially towards the body, we see the subscapularis here in the front, supraspinatus, infraspinatus, teres minor. So this is the rotator cuff, the front of it, top of it, and then the back of it. In the posterior part, the two muscles, infraspinatus looks normal, and the teres minor back here looks too bright. So this is the main finding here. This patient has edema within a single one of the muscles. This is the teres minor muscle. And when we see this, we think about an injury of the axillary nerve. The axillary nerve goes through an area called the quadrilateral space over here, and it innervates the teres minor muscle, also the deltoid muscle. And sometimes patients can have injuries of that axillary nerve that will cause edema and atrophy of deltoid and teres minor. Sometimes it's just the teres minor muscle. There's variable anatomy for the axillary nerve. Sometimes a branch will be injured that goes to this, but it may not hit the branch that goes to the deltoid muscle. But in this patient, the deltoid looked normal. It was just isolated to the teres minor muscle. So in this case, we say this patient has atrophy, or just minimal atrophy and edema of the teres minor muscle. We suspect that there may be an insult to the axillary nerve. We'll look in the quadrilateral space over here to see if there's a ganglion cyst that's pushing on the nerve, if there's a neurological tumor, a schwannoma pushing on it, or if there's inflammation in here. Most often, though, they have an occult injury. They have repetitive microtrauma. They could be injuring that nerve. They could have an old injury with some scar tissue in there that's injuring it. And in this case, we do not see anything in that quadrilateral space, but we surmise that there is an injury of that nerve that we just don't appreciate. So this is that quadrilateral space here, and this is the nerve. And again, here it is. So this is what we call quadrilateral space syndrome. We suspect that there's an injury of that axillary nerve, and in this patient, it just does not happen to cause the atrophy of the deltoid muscle, just the teres minor muscle. And this is probably the cause of this patient's pain because everything else looks completely normal. Thank you very much.